Can you guys on Zoom hear me?
I know.
Oh, yeah.
So this is showing this, but it says that screen sharing this.
If Evan can hear you, you definitely say something.
Yeah. Well, I thought, I think I heard him a second ago.
Oh, really?
You know, you have his number. You text him and ask him. And then also ask him if he sees like a video or if he sees the. It should be right. I think this has both. Yes, I think that's the camera and the mic, but. I want to make sure you can see it.
I can see the slides on Zoom, and sometimes I can see Robert's polo, but it does sound like you guys are underwater for most of the time when you're speaking.
Okay, I'm gonna try to move the camera a little closer. Okay. Can you hear me okay? Not at all.
Yeah, that's a bit clear.
Okay. I think I turned the mic volume up. Can you hear me?
I'm sorry, could you, I cannot hear.
Can you see the
Yes, I can.
Okay.
I can hear that and see the PowerPoint.
Okay, perfect. I'll give it a minute. Okay, if you need me or IT, just give me a call or hold it.
This is I'll be talking like the wrong direction for this. I'm trying to see what I can do. Bring it a little closer. Table. What I can also do is go and do my laptop and talk from there.
Okay, I can include you on that on the
Yeah,
link.
I might just do that instead. I'll wait and see. Yeah.
If y'all are having trouble with the microphone, just have Andrew Bruce transcribe it all and put it in the chat. That seems like it'd be pretty reasonable ask for his friends down in Altus.
Evan, is the mic right here? No. Is the mic right here?
I mean, it sounds like a Korean War era walkie-talkie, but I can hear it.
Beautiful. We haven't really done any people from doing this in myself, as far as doing a little strange.
Mute your laptop.
Okay. This is still gonna have feedback. Let me see if I can.
Oh yeah, it's giving a fair bit of feedback.
Yeah, I know. Let me see if I can. What would be the best way to? Yeah. Let's see. All right. All right. I'm gonna exclusively hear you through my computer laptop. Oh, that's gonna be weird too. Just hear myself echo the whole time. Okay, that works for me. All right, Evan, can you hear me okay?
Yes, I can.
Okay, cool. All right, not too echoey on your end?
No, it sounds great.
Okay, cool. I think we finally found a setup that actually works. All right. Okay. If you and Emily can turn your webcam on, that way just make sure I see you all. Cool.
I'm so sorry I got stuck in traffic. There was like standstill traffic in Ardmore, and so I'm in Norman. I'm almost home.
Okay. All right, that should be okay. All right, so let's go ahead and get started. Y'all driving? Okay. Yeah, it's all right. Whatever safe for you guys. It's you don't have to get distracted by all this. Okay, that's fine. I can at least verify that y'all are here. Like, I think that's fine enough. And you just turn your camera on whenever you're at home or in a safe spot. Okay. Anyways, we can go ahead and start out. My name is Dr. Chow. I'm actually a pretty new family medicine attending. I actually went to medical school here at OU, graduated in 2019. So I was in your exact same spot you guys are right now about 5 years ago. So, which sounds weird, to be honest, like half a decade ago, which does not, it really just seemed like it was like not like a year or two ago even. So So it moves pretty fast, I would say. I went here for my residency, and I stayed on here afterwards. I basically found that I really enjoyed teaching. On top of just like taking the care of the type of patients we see here at OU, which are super complicated, and so it's constantly pretty like intellectually engaging, at least because people there not only do they have the typical stuff that people have like hypertension, diabetes, but they have rare stuff. They have um, a lot of extra factors involved that make them more complicated, especially the social economic factors. So sometimes I end up having to play social work, trying to get them set with certain uh, resources, local resources, to make sure they get good care. So I really enjoyed that kind of that challenge, and also enjoy teaching people. I really did not know I wanted to do this until I was a third year resident, when I actually got to be in a more of when I got to be more in a teaching role for the lower level residents, and I really found myself enjoying that. So I am very happy to be here and kind of be teaching all today. How's your rotation going so far?
Really good.
Good. Okay. See anything interesting?
I saw herpes for the first time.
Oh, cool. Nice. Did it look like dewdrops on a rose petal?
No, no, it's not.
Okay.
It was painless.
Oh,
So I
not that
didn't-
romantic.
I didn't want it.
Okay. Yeah, no, it's a so the in more medical terms, it's a clear vesicles and erythematous base, and it's pretty they don't they can kind of like cluster and make these little like kind of confluent like lesions, but most of the time they kind of look like individual little vesicles, and they could be in kind of different stages as well. So you'll see that a good number of times. It's pretty common, a lot more common than people would like to think about or accept. And most of the time, it's not really worth checking for herpes. Especially if you don't have an active lesion, it's really not worth checking because they might be positive, they might be negative, and it's not even like the predictive value of the test is like really low if you look it up. I forget what the actual percentage of it is, so it's not particularly helpful. A lot of it is really just based on 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 actually seeing it, and also just like treating it whenever it comes up for the most part. So it's a lot more common than people think. Basically, as long as you don't have like lesions, or tend to have lesions, and you're pretty much safe from like transmitting it. But at the same time, like that you can shed like a day or two before you actually start having lesions and stuff like that. So it's a little tricky, but it's almost things like they have to be aware of it, if anything. And they know they'll know they have the history, and then oftentimes they'll be on some suppressive therapy. Oftentimes, like I give my patients like a few extra courses for them to take, in case they have a flare up, so they don't have to just come to me for an off visit just to get a refill on their valacyclovir, the Valtrex, and it only requires like 3 days of treatment, and then it'll help decrease the length in which they have the outbreak. It's not going to straight up cure it, but it might cut it down to like a couple of days at least. So yeah, and so it's not something that we see that relatively common. Yeah. Anything else interesting?
We had a patient who had a large, thick, like lesion on her forehead, and unknown, we don't know what it was. She
Yeah.
bumped her head like 6 years ago,
Hmm.
and it's just been living there.
Interesting.
And we did an ultrasound, and it didn't show much fluid, so
Is it
I'm curious about.
could have been like a lipoma?
We thought maybe lipoma, but there was
Yeah.
some fluid. We
Okay.
don't expect that to go away,
Yeah.
so we're gonna.
Interesting.
give
Yeah.
it a derm follow-up.
Okay. Yeah, that's interesting. Yeah, no, and lipomas tend to like to occur in areas of high friction, or as a result of high areas of friction, or like just places that had previous like kind of injury too.
She would often get her hair braided back really tight too.
Hmm. Interesting. Nice. Yeah. Oh, you're gonna see a whole variety of skin lesions kind of throughout your throughout your medical career. Probably just about anything you go into. Maybe not like psychiatry, I guess. Well, you might see it, but just you don't have to mention it, I guess. But yeah, I mean, it's good to have like a vocabulary, and that will actually help guide you towards what you what you think it could be. Is it like well circumscribed? You feel like an actual like kind of defined mass underneath? Is it more just kind of flat, broadly, like a kind of broad base and flat and raised? That's something completely different. Is there erythema on top of it? Is there discoloration on top of it? How firm does it feel? And all that can kind of guide to what you think of the lesion is. Of course, the different diagnosis is going to be a biopsy, but you can kind of guide your judgment based on kind of your vocabulary you can ascribe to some of these lesions. So that's something that is kind of pretty big on derm. It's like you have to have like, it's like, oh, this person has a lesion. And then like, that is absolutely unhelpful at all. Like, and then you say, have to be like, okay, this is a macule, like a raised macule, it's erythematous, like erythematous raised macule, well-defined borders. There's a lot more kind of adjectives to that. So, yeah, but yeah, that's kind of like my recommendation for kind of figuring out what is, because you actually can look it up. You can see like what's this like you say like raised macules, and you might actually have like some, if you're actually trying to look it up and see examples of it, you might be able to kind of find closer to what you're trying to what's actually going on. Okay. Anything else kind of interesting? Oh, okay, cool. Yeah. What was it due to?
Yeah, she stopped OTP back in November and I've had a great since.
Interesting. Has she ever had has she had kids and stuff like that before? One kid. Was it like a pretty traumatic birth?
Some of it helped, but
Okay.
negative on pregnancy tests multiple times.
Interesting. Yeah, it can be caused by a variety of things. I would say the more common thing will probably be like thyroid disorder, because if a thyroid disorder, that can really throw off your cycle, and that's not particularly common. But then you can have all the other ones that people can get whenever they might I forgot what the term of it is, like commons, we have like I think like bleeding to the pituitary gland or something like that. There's something like that, but there's like, I don't think I really ever came to that in person, but more common. What? She hands. Oh, she hands. Yeah, she hands on attachments. She hands. Yeah, I think she. It's one of those. It's one of those like terms that you learn about in medical school. You just don't come across that much in actual real life. Let's look it up. Yeah, it's an injury to her gone following extreme blood loss during childbirth, and that's kind of what I was asking if her one birth was particularly exciting at all. So, all right, it's okay, cool, nice. It's generally kind of fun. I mean, she also can have like PCOS and stuff like that. It's also another relatively common reason for amenorrhea.
You see any secondary symptoms of PCOS?
Oh, really? Okay. So yeah, if she normally has normal cycles for most of her life, if she doesn't have any hirsutism, and if they've never seen any cervical barren cysts on the ultrasound, then you can be pretty sure they don't have PCOS. Okay. Generally need about two out of three things I said in order to diagnose with PCOS. So hirsutism, amenorrhea, or there's just kind of inconsistent cycles, and then an ultrasound confirmation of multiple ovarian cysts. Okay, cool. Anything else?
I had a patient that had a stroke on Saturday and they came in on Tuesday and their blood pressure was 170 over 110.
Okay.
And they refused to take antihypertensives and they said they lived for danger. So that was
Oh, that's fun. Yeah.
interesting.
It's like, which I guess he wants to be spoon fed the rest of his life,
Yeah.
like and not walk and have a really horrible quality of life, possibly following a stroke. Yeah. So yeah, you can only help people to a certain degree. That's something I did struggle with as when I was kind of starting, was like, it's like I'm trying to save everybody, But the thing is, some people there's a certain degree in which you can only help people as much as they're willing to help themselves. All you can do is really just tell them like, hey, this is why I'm worried about it, and this is what I would personally do. And so I'm not telling you this just because it's like, I'm just to just to do so. This is something that I would actually do, and this is why I'm worried about why I would do it. And sometimes they'll respond to that, sometimes they don't. At that point, you'd be like, okay, well, all I can do is just document that this is important and can lead to death and all that stuff, and then they'll kind of help protect you on the medical legal side of things. But also, in general, like there's some degree which you should kind of put up a fight in terms of like try to convince them. But there's some people you just know they're like pre-contemplated, like no, no, I don't have any desire to do that. At that point, you don't have to waste your breath and energy on that. As after you kind of tell them the things you're worried about real quick, like, hey, like this, you can die from this, and they're like, okay, and then you'd be like, okay, should I acknowledge this risk, and that's usually good enough, and they'll help you a lot, even though it'll feel weird for a while, because just be like, okay, this person's gonna probably not going to live very long as a result of this. And then you just have to kind of be okay with it, not take it too personally, like it's a failure on your end, especially if you made like an earnest attempt to try to get them better. Yep. All right. Anything else kind of interesting?
We had a lady with like really poorly controlled diabetes.
Okay.
Doesn't even have her toes anymore.
Yeah.
And she like had crazy like glucose was like 500 and stuff, and now she's on insulin. And so she was like having like hypoglycemia symptoms with like a glucose of like 110.
Mm-hmm.
So it's just interesting to see like just how her body adapted and how she has like a new baseline.
Yeah, because one day it's like elevated for most people, and then for them
And
to
she's
be
having
symptomatic.
hypoglycemia and, like, lightheaded and stuff.
Yeah, I had a patient a couple of months ago. A1C of 15.5. Like when I checked his like glucose in clinic, it was undetectably high. It just does the meters that we have in clinic just does not go that high because it's how high his glucose was, and he was just convinced that he did not have diabetes. He's just like, oh, it's just liver stuff. Well, like, oh, my doctor's just like, well, because of liver stuff, I could maybe have some like blood sugar issues. Like, I don't know. Like, I think like I am like near 100% sure that this is like diabetes. It's like, I don't know. Let me talk to my liver doctor. I'm like, if your liver doctor tells you this is not diabetes, I'm going to report him to the medical board because he's absolutely wrong. It would be absolutely wrong. And it literally took me like 30 minutes of trying to convince this person to actually go and like stay there just to get started on some insulin, at least like bring it down more acutely in the clinic. That way we can check his electrolyte afterwards. Because ideally, when it's that high, they probably should go to the emergency department and be hospitalized and get kind of like slowly lowered on his like blood sugar and kind of replenish those electrolytes as needed. Um, but this person absolutely refused to go to the emergency department. So I had to do what I can do and what I can do in the office. And so I at least told them like, hey, we can at least do it in the office. We'll go through this protocol, get you in a safe range, and then we need to check your electrolytes afterwards. And the main thing we want to check for diabetes is going to be potassium. Okay, whenever you give someone insulin, potassium goes intracellularly, but also it's like glucose and potassium goes intracellularly. So a common problem you're going to have is going to be hypoglycemia when you start people on when you acutely lower people's blood sugar. So that's the main thing I was worried about for him is make sure he's not hypokalemic. And so I was like, had all this planned. I even got him like we had some like available like glucometers and test strips and in the clinic that was able to just like hand him so he can start testing himself at home. And then even had like samples of long-acting insulin for him to take home and start immediately, so we can start on getting him to like a sort of better place. I told them about risk of stroke, or like increased risk of stroke by having diabetes, also risk of like more immediately risk of diabetic coma or seizure and death. And he's like, yeah, like like I think I live a good life. Like it got something like that. But it's like so it's like and then I just start talking about like what do you live for? And it's like, oh, I really enjoy like taking care of my grandchildren. And it's like, okay, I want to tell you, even let's say at the very least, like diabetes is a slowly destructive disease. Like if it's not taken care of, kind of like what Slay was having. Like, you can lose a foot, you can have a below knee amputation, lose like basically one of your lower limbs essentially, and then and oftentimes like the other leg, it doesn't fall too long after. You can go blind, you can have a heart attack and stroke. It's a terrible life. It's a really hard life to have uncontrolled diabetes, and so it's not like you're not gonna if you don't die immediately, it's gonna be not a quality of life I would want for anybody. And like, and more importantly, you won't be able to spend time with your grandchildren. You know, do you think you'll be able to run around and play with grandchildren if you're unable to, if you don't have feet anymore? You know, and I think that really kind of resonated with him. And so unfortunately, he says, "I'm gonna go get a cigarette break," and then he proceeded to drive home afterwards. And so, but then he did call me the next day and was like, I apologize. I really thought more about what you said, and I do want to get started on insulin." And I saw him for follow up this week, and his A1C is now 7.2. So, that's kind of an example of like trying to help people as much as you can, but you know, there's a certain limits of it because I was ready to give up on him at that point. I was like, okay, I think I did my thing. I think I did the nice, like, you should probably get this done, to like, you're gonna die. It's not gonna be a fun death like whatsoever. It's not gonna be easy. It's gonna be horrible. Like if you don't stroke out or have a heart attack, you know, then that's actually probably more of a preferred outcome than having to live with this, to be honest. And then like something that scary, and that didn't quite work either. But then but actually appealing to like what they care about, what matters to them, and kind of going off of that was probably the most helpful. And that's kind of what the like motivational interviewing, if you remember that from Clint Med, that's kind of like why that's important, because you want to see what their values are and see what they care about, and you'd be surprised how much you can convince people to do what they need to do in order to just with that technique. Literally, it's just as simple as that. So hey, it's like, why, from a scale of 1 to 10, how ready you are to change today? They're like, oh, I'm about a 5. Okay, so why you say a 5 rather than a 7? You know, it's like, oh, I think it's gonna be, you know, expensive, blah blah blah, you know, something like that. Like, okay, and why would you say 5 instead of 3? It's like, oh, I know how bad this can get. You know, I heard about horror stories. Like, okay, sounds good. And just kind of figuring out like what matters to them in that way. And so it's a nice little kind of like, it's like a cheat code to kind of figure out what are the values, and seeing how you can use that to kind of guide them towards like a goal that they actually want, you know, because sometimes some people are just hesitant to listen to doctors, to be honest. And that's going to be something we're going to talk about with, for example, our reading with the virtual mentor to a certain degree. So yeah. Anyway, that's all right. That went off on a really, really like a tangent. But yeah, I deal with diabetes so much, and it takes a lot of educating. People just don't, they just get like high blood sugar, and they just can't correlate that to like true like kind of illnesses, and or like just like something more tangible, versus like being doctors, you see the tangible effects of high blood sugar all the time in every specialty you're going to go into. Like in surgery, they hate diabetes because they're not going to heal very well. They're going to have post-operative infections all the time. I mean, it's kind of in everything, you know. Maybe not quite psych, but I feel like there's some psych components as well. So yeah. Anyways, cool. All right, we can go ahead and move on. This make sure I still am. All right, okay. All right, so objectives today is going to be about diabetes, which we've talked quite a bit about, and hypertension. So we're just going to kind of talk about the recommended guidelines for those things, how to pick medications, because there's a lot in your toolbox for both of these conditions, and it's important to kind of figure out like, sometimes it's like really choose whatever, but sometimes there's situations in which one will be more ideal than others. Okay, so we're going to talk specifically about that, and kind of go from there. All right, well, so now I think I kind of covered a lot of that stuff, kind of like, you know, different things about patient care and the complexity involved with that. So I'm gonna lower that a little bit. Actually, let's get rid of this. Okay. Don't forget to complete your evaluations. All right, we already talked about that, Bob, this week. So this is our kind of our longitudinal patient that we're taking care of. Let me see if we can hide. Hide flow controls. There it goes. Okay. So a patient with symptoms like Bob of that has an increased thirst and urination can be diagnosed with type 2 diabetes based on which random glucose level. Yep. Anything above 200. I don't have that on here. Oh, sorry, but yeah. And then fasting 126. This is a little, sorry. I am confusing myself by having a keyboard in front of me and I have two keyboards in front of me. Okay, so what's the best first line therapy for type 2 diabetes with hemoglobin A1C of 8? No. Yeah, I think this one actually has two correct answers, to be honest. Uh, in general, like, yeah, like I'm not sure what the official correct answer on this, to be honest, is, but I think it's like literally it could be A or D. I mean, it's kind of a little on the higher end for me, to be honest. If anything, they should be doing diet exercise starting like 6.5 when they start crossing in, or like 6.6 when they cross into true diabetes range and not like pre-diabetic anymore. Then they should go and diet exercise. But usually around 8, we should start on an additional medication just to kind of get it down a little bit quicker. But also it's just like a good medicine to be on, and they'll kind of work together synergistically to kind of bring it down lower. If you kind of look at on Up to Date, it has a really nice list of it has this really great chart that I refer to all the time in their management of diabetics, which talks about all the different medications and interventions and how much you can expect the A1C to go down. And metformin is about 1 to 2, and diet and exercise is about can be up to like 2 or so, possibly more depending on how good they are. But reasonably, I don't know. It's just not. For some people, diet and exercise can be really hard to do. It's just like it takes a huge lifestyle change, a whole new different way of how they think about what they eat, and sometimes you're just not confident to be able to do that. Okay, especially if they're really obese and they have this really poor exercise intolerance. Like it's gonna be hard to bring it down on just that alone. But if anything, you should be doing both for any diabetics, type 2 diabetics specifically. Okay, what explains Bob's symptoms of increased thirst and urination? Yeah, okay. The subject of today's lecture, this is kind of, I was hoping to ask them more like, oh, it's probably due to this like polyuria. Yeah, but that would have been probably a little bit better, but no. Or glucosuria, which leads to polyuria, which leads to polydipsia. Okay. All right. Which is following is the diagnostic criteria for type 2 diabetes? It's D. Yeah. Yeah. So yeah. So basically, yeah. So technically, like, so we don't do anything general until it hits like 7. That's kind of what the general rule of thumb is, like, because when they're like 6.5 or higher, like at that point, that's perfect time to start making some dietary changes. It's like I tell them like, hey, officially you have diabetes, but what's nice is that you're at a perfect place to not need any medication still. So, so at this time, this is the perfect time to start making some lifestyle changes, and you can be off of medication. You don't have to be on medication for that. Which we're at right now. And then some people be like, oh, great, like this is perfect. I can avoid being on a daily pill by doing so. And you can kind of use that time to kind of encourage them to actually start kind of looking more into that, kind of discuss like what type of foods you're worried about, because most people think blood sugar, think sweet stuff, but they don't think about breads, pastas, rice, and stuff like that. And that's kind of mainstay for a lot of people's cultures and stuff like that as well. And so so that can be tricky at times. But just let them know, like at least portion control, especially for kind of carbohydrates, will be very important kind of going forward and stuff. And just like you just have to kind of assess their level of education and just see how much you need to like counsel on that. And you should, because the amount of time you spent there can pay off. Like the 10-15 minutes you spend like counseling on food and stuff like that can be pretty effective for the right type of patients. Okay, here it goes. So basically, these are kind of the more the technical definitions. So diabetes 6.5 or above, pre-diabetes 5.7 to 6.4, fasting glucose above 226, or 226 or above, any basically above 200. Best way for screening Bob for diabetes. And the keyword for this is screening. I know. Yeah, yeah. One of the previous lecturers on this put D as a joke on an answer of this PowerPoint, so that's why I had trust issues about this. No, but the answer is A. So the idea is screening. Okay, you shouldn't be just doing A1Cs on everybody. You should at least like check your blood sugar first, and then like just in office and just see what it shows. If it's elevated, then go to an A1C. If it's not, then you can be like, if it's like 90 right now, like, and they're like talking to you, sitting there, then you can probably be pretty sure that they don't have diabetes. And some insurances might not cover your A1C if you don't have a documented elevated finger stick reading as well. Yeah.
So is the finger stick the better screen versus the urine creatinine?
So that one's more of a like that could be like a later one. It's just not as specific, you know. That one was that you generally see some changes in kind of urinary stuff kind of later in the disease process, because even if you have, let's say you have like A1C of like 7, there's a good chance you're not gonna have any glucosuria, any like microalbuminuria. So some of the later stage of like kind of kidney of diabetic disease, then you'll have like more urine protein and stuff like that. So this is to at least encapsulate everyone, even with like mild disease. So if anyone, the thing is the key of this one is screening. So it's a finger stick. Diagnostic is going to be A1C, but not all the time. There's a specific group of people that A1C is absolutely unhelpful for. There's a couple of people it's absolutely unhelpful for, but there's a main group. Sickle cell, yeah. It's all about like you just the surface is just not as favorable to attach like glucose to, because what they're doing is they're literally measuring, looking at your glucose and see how many percent of them have glucose on them. And with the abnormal kind of morphology of sickle cell, they just don't have like this. It's just not. I guess it's not conducive for just the attachment of it. So you can't use A1C. I believe for nowadays you recommend, I want to say like fructosamine, but let me double check that. It's been a little bit since I had to check on that. Yeah, use fructosamine instead. To there's one other test that's also recommended for diabetes, like for diabetes and in sickle cell patients. It's also not great for people with acute blood loss. So basically, they somehow lost a lot of blood recently. Then it might be mostly predominated with new blood, and that could artificially lower your A1C as well. Okay, which of the following are recommended for patients with type 2 diabetes? Yeah, the annual dilated eye exam. Pneumococcal is not annual. If anything, it's like once before you're 65, and then I think now just once after you're 65. There used to be 2 different shots after 65, but I think that with the new Pneumovax, it's really just like a one-time shot, which is really nice. Monofilament, you just basically need to do that about once a year. Finger sticks, it's like, for example, like if they have an A1C of 6.6, do they need to be testing their blood sugar 4 times a day? No, not really. That's you only test people 4 times a day if they're on insulin. If you're sort of concerned they're kind of getting there, then you start maybe doing daily finger sticks. But if they're not on any insulin, then they shouldn't just be on once a day glucose checks. And then A1C testing annually, that one is like, I don't know, like sometimes if you're trying to get better control, you should be testing them every 3 months. So you try a new medication, you test them 3 months later, see how much it actually lowers the A1C. It all depends on like the frequency in which you test A1C depends on how well controlled it is. You know, if they're like been 6.6 for decades now, then I might not even check annually. I'll be like, I don't know if it's like, if you want to, we can check it again, but I don't know if it's going to change anything. But at the very least, I think I at least get annual A1C testing on people, even though they're mostly well controlled, just to make sure it stays like that. You don't know if some people might have a bad year and then had a poor diet all year, and usually trying to keep an eye on that. But it's not it's not recommended per se. A lot of it's on a person to person basis. Which of the following has advantage of weight loss but can cause pancreatic cancer? This is incorrect now. I think they just did a meta-analysis on it and they found no correlation of it. Yeah, it's D. So, yeah, yep. It's because technically it works on like the on directly on the pancreas, and there's like concerns of it causing like kind of like pancreatic hyperplasia or something like that, and that has a like a theoretical risk of pancreatic cancer, but they really do not see an increased risk, increased incidence of pancreatic cancer in people taking GLP-1s. So it's actually really, really safe. All right, medical social interventions on delayed or prevent type 2 diabetes. Yeah, not surgery, not particularly helpful, but if you notice on the very bottom, bariatric surgery has the highest reduction in risk of type 2 diabetes with a pretty strong p-value. All right, nice. So these are kind of your main toolboxes for this main toolbox for diabetes. In terms of ones I actually use, maybe 4 of those really if on a regular basis. 4.5. There's this one I kind of use sometimes. We can talk about them as we kind of go through these sections. So the different types for non-insulin kind of medications. Acarbose just works by delaying carbohydrate absorption. We don't use that very much. The benefit of that is like it's cheap, and so for people who are unsure, that might be a decent option. I'm not sure how consistent control you can get from that. I just don't come across it that often. Sulfonylureas, they increase insulin secretion. The main problem with these and the reason why I hate using those and try to even get all my patients off of it is due to like hypoglycemia. This is probably one of the few medications on this list that can cause hypoglycemia. Just because if the dosage is too high, you're causing way more release of insulin than what is needed, and they're at risk of hypoglycemia. So elderly people shouldn't be on this, because that'll increase the risk of falls and everything. And plus nowadays, it used to be the second line drug. It used to be like metformin doesn't work, get them on a sulfonylurea next, and then they can get on one of the more expensive ones. But now with how good the data is for all the other medications, it's no longer like particularly second line. You have so many other options for it. Biguanide, metformin, number one, everyone should be on it. Basically, if you're on insulin, you should be on it too, just because it makes your insulin go farther. It works really, really well. The main thing you want to worry about for this is going to be lactic acidosis. So if someone's admitted septic, they shouldn't be put on metformin. Next is going to be DPP4 inhibitors. These are pretty. This is glucose dependent insulin secretion, so it has less of a risk of hypoglycemia. The downside of this with this particular drug class is that, in my experience, it doesn't lower A1C that much. Like in general, I can maybe expect like maybe a 0.5 decrease on it. It's just not that strong. Okay, if someone's like almost there, you can maybe just add one of those. They're like, I don't know, like a 7.2, 7.1, and I just need a little bit more. Then you can add those on. They'll get them into a good range. Glenides, I have never prescribed this per se. Yeah, I really never have prescribed it myself. I think I have whole patients that might have been on it, but I've never particularly prescribed that. GLPs, these are going to be your this is going to be this is effectively my second line drug. Okay, if they can't tolerate metformin, then I get them put on a GLP-1. Just because in general, people with type 2 diabetes tend to have obesity, and being able to decrease their weight with a medication too is so huge. And so this is why I get a lot of people on. And so some people that want to be put on this, like Ozempic, Trulicity, Mounjaro, like those are all GLP-1s that everyone wants to be on, and people are prescribed it with no indication outside of obesity, and it's going to get turned down by insurance now. For a little bit, insurance were pretty lax on upholding that, but now it's like almost impossible to get someone on it for just obesity alone. But it's so effective for weight loss. What's nice about it is like, so if you actually look at the weight, so some of these have like weight loss dosages of it, and they're actually about twice as high as the max diabetic dosage. So Wegovy is like it's like 3.4 of like I want to say like liraglutide or something like that. Saxenda is like 3 point something, and then the max dose for diabetics are like 2 milligrams per week. So it's actually higher. Like so weight loss dose is actually generally higher than what the dosage is for what you get for diabetics. But that goes to show you how safe it is and not causing hypoglycemia at the very least, because it's only glucose dependent. It does a lot of different things, so slowing gastric emptying. So you have early satiety, you get full faster because it's just like food is just not moving through your gut nearly as fast. So people have pretty consistent weight loss on it. I generally expect around like a 10 to 20% weight loss with that once you can kind of get them on a good enough dosage. Okay. SGLT2, that's also a really good one. Increases urinary excretion of glucose. The main risk of this is going to be, of course, UTIs. We have more glucose, which is UTI food. You have a higher chance of having this bacteria growing there. Is at further increased risk of it, but it has a lot of cardiac benefits. So that's actually one that I don't use. Something that I actually use relatively commonly for people with really bad heart disease, because it's so good for heart stuff that is now given to people without any diabetes if they have bad enough heart issues. And that's how good it is. I can't tell you exactly what the mechanism is for that, because from my main understanding of this, it works at the level of the kidneys, but it does something at the level of the heart that's shown to have like really good data on people that are even non-diabetic. So you might see people see some heart patients on Farxiga with no history of diabetes, and that's empagliflozin. And then the TZDs. This one increase glucose uptake in muscles and fats. Don't really use it nearly as much either. I think the main problem with ones that it can cause like a lot of like kind of swelling and stuff. And so it's not especially not great for like heart failure patients when they have swelling issues to begin with. So in general, in terms of ones that I generally use in clinic, it's going to be metformin. The half point I gave to the DDP for, it's just like because it only reduces things by half, so I don't use it that often. I just mostly use metformin, GLP-1s, and SGLT2s. Okay, and those are probably the most common ones I use. And I believe you can basically, if they fail metformin, they can qualify for GLP-1s now. Before these, they have to try like 2 or 3 other medications in order to get that approved. But even though sooner care, they'll accept it if someone has been on metformin for at least 3 months. So it's a really good medication. So why not use the best medication that doesn't have a risk of hypoglycemia, that has minimal side effects, that helps with weight loss? Okay, so this one talks about monotherapy, dual therapy, triple therapy options. So those are just kind of those you can kind of look over it. Algorithms for intensifying insulin. So, yeah. So, let's see. This is just kind of a busy chart. Do you guys have copies of these slides? Okay, yeah, you can just look through it. I don't want to like read through all the boxes on this, to be honest. It's a Friday. We all want to get home and start our weekend early. Long-acting insulin. So these are kind of the main ones you're gonna see. Most of the time, you hear people use it by their brand names in clinic. Lantus, Levemir, Toujeo, Tresiba, Basaglar. The most common ones I probably see is Lantus and Basaglar. I'm seeing more people on Tresiba and Toujeo. I think it's I want to say Levemir is the one. Yeah, Levemir is the one that technically doesn't exactly last 24 hours, but we treat it as such. Sometimes some insurances just prefer it, even though it's less ideal. But most of the time, you get people on like Largy, which is probably the most common long thing I use. Tresiba is a little bit trickier because it lasts 42 hours, but it helps maintain their basal insulin a little bit better. But it's just a tad trickier to dose because you have to like kind of think about the fact that it's lasting close to 2 days. with it. So it's not as great of like a kind of one-on-one like kind of translation from the other long-acting ones. Management diabetic nephropathy, control blood pressure, glucose, lipids, focus sensation, ACEs and ARBs. So basically, you want to start diabetic patients on ACEs and ARBs just to kind of help prevent diabetic nephropathy. That's kind of the main point. And some nephrologists even put people, some nephrologists and just family medicine doctors even put people on small doses of ACE, even to have no kidney issues or even don't have blood pressure issues, just as a preventative. So you might see people on like lisinopril 5, which is like even below the starting dose of lisinopril, which is 10 generally, just as almost like, I don't know, good luck, renal protective stuff. You know, I don't know. I'm not sure how good the data is for such a small dosage, but I think they kind of do it just in. I want to say they probably do it just in case. Okay. All right. Diabetic retinopathy. So kind of it's an important thing to think about diabetes as as much of it is as an endocrine problem. It's also a vascular problem at high enough levels, because what happens is that the blood gets thicker thanks to the glucose, and they stick together and they tend to clog off micro vessels. Okay, so that's why you have peripheral neuropathy. The mechanism for peripheral neuropathy is that the small vessels that are supplying circulation to your small nerves in your extremities are blocked off, and so you're no longer getting circulation towards those nerves, and they slowly die off, and that's why you have peripheral neuropathy. And so if you want to think about that in terms of what that can cause throughout your body, so that's why you have increased risk of stroke. That's why you increased risk of heart attack. That's why you have diabetic nephropathy, is because you have all these small vessels within your nephrons that can get blocked off and cause some long-lasting damage. So don't hesitate to think of it as also a vascular disease as well. So based on that concept, that's why we worry about kidneys. That's why we worry about eyes, because you have a lot of tiny vessels in your eyes. You're trying to make sure that they don't have any signs of retinopathy. All right. Management. So basically, control your glucose, blood pressure, lipids. For active retinopathy, refer to ophthalmologists. They have a couple of interventions they can do for that. All right. Assessment of diabetic neuropathy, kind of back to what we're saying. You're just kind of, just once a year, you do a monofilament test, which is a little kind of pokey. I don't know what it's made out of, like metal or something like that. Something really bend, like really flexible thing. Just basically just poke at the tips of their toes and at the kind of the balls of their feet and stuff like that. And then basically see, like, tell them to close their eyes and be like, can you feel this? Can you feel this? Can you feel this? Can you feel this? And then what's nice is that they even have the picture of where you need to poke on the actual monofilament most of the time. So you don't have to remember exactly like where on the foot you need to poke at. They'll tell you exactly on the actual thing itself. Neuropathy evaluations and tests. So for the spectrum neurologic testing, peripheral neuropathy. And the thing is, like, what's unfortunate is that diabetic neuropathy is mostly incurable. There's a certain degree of it's like more, there's a certain degree in which you can kind of improve a little bit, but usually it's been there for a while and nerves are just like dead at that point, you know. And the main thing you can do, maybe I just try to counsel people is like, hey, you're having a lot of pain now. We might be able to improve a little bit with better control your diabetes, but the most important thing is make sure it doesn't get worse, because it can get a lot worse, you know, if we don't take care of it. And so some people will just be like a little disheartened about like, oh, I'm still having all this pain despite my A1C being great now. It's like I'm I'm sorry. It's just kind of like I think basically the damage is done, but what you can't do is make sure it doesn't get worse, because it can get a lot worse. Because that's kind of one of the reasons why people. So why do you think people get foot amputations from diabetes? Yeah, yep. That's a big part of it. Another part of it is just the vascular stuff. So you generally have poor vasculature down there, like in terms of like if like so sometimes those microvascular kind of occlusions become macrovascular, and to the point where you just have terrible circulation down your feet. So anytime we see a person with a diabetic foot ulcer, and maybe a concern for like an osteomyelitis, what we need to do is check for what's called a PCO2, which looks at your kind of like the ability to transport oxygen to your extremities, and that will determine to what degree they can actually heal. Okay, if they have good healing potential, then you can just give them antibiotics and they'll do well. If it has poor wound healing potential, then it needs to be amputated. That's what we call our ortho colleagues, and then they go and chop off a foot for us, or a knee, or basically they're like a blow knee, depending on how bad the level of the infection goes. But yeah, so basically it has so if it has poor circulation down there, you're not going to be able to send antibiotics down there. And so that's why it's a big deal to kind of for ulcers and stuff like that. So basically they have poor circulation, they can't feel it, they bump into something, don't even realize it, they can't heal from it because they can't send white blood cells there to kind of fight off infections. And so at that point, it's just going to be like a raging infection until it gets to healthy tissue. But ideally before then, you're going to amputate just to prevent that from happening. Keep going. Let's see. Statin use. So basically, people with diabetes, because we talked about how diabetes is a vascular disease as well. What you want to do is to decrease the risk of heart attacks and strokes by also being on a statin. Okay, statins are so important. I love using these. I mean, they should you should have a low threshold for putting people on it. Basically, most type 2 diabetics should be on a statin because it will decrease the risk of cardiovascular risk. Statins, not only do they lower your LDLs, what you read about, it actually has like a plaque stabilizing component to it. So for example, some of the other medications that lower your LDLs, like ezetimibe and stuff like that, they don't have the same mortality benefit. They don't really see people actually living longer on those medications. They see people living longer on statin. And so in general, statins are like, I don't know, like you really shouldn't be leaning on any other medications other than statin. If they can't tolerate it, go on a lower dosage or switch to a different formulation. Sometimes I'll be like, oh, I have like the main side effect that we're worried about for statins is going to be statin-induced myopathy. Okay, and so that's when it actually goes into your muscles and attacks it. But there's also statin-induced myalgia, which is much more milder, and it's actually for that it's not like clear indication to stop statins. The true myopathy, when you actually have elevated labs like CPK and aldolase, then they should probably not be on statin, but they just have some pain on it. You just have to mess around with the dosage of it. You just have to cancel patients. Like no other drug is going to decrease your risk of heart attack and stroke by 50%, the same way that a statin is going to do so. So that one is one of those ones that's like, I don't have especially people with high, not particularly high cholesterol, we put them on anyways, and they just have to kind of convince them that they should put on, because even people with kind of good cholesterol, it has decreased mortality rates for them. I've heard some people using it. I'm not sure about the efficacy of it. I mean, I heard it's relatively good from what I understand. There's also like red yeast rice that actually has like statin-like abilities and even plaque stabilizing capabilities as well. But it's just hard to say like how much of that you need. I've definitely seen more people use it. Maybe that the CoQ10 is something that I've seen some patients be put on if they can't tolerate statins at all. So I wonder I wonder what the data on that is. I haven't looked it up personally. So vaccination of type 2 diabetes, kind of what we're talking about. They need to get the this is outdated now because we have this new Pneumovax that covers a lot of these. So but before the 64, they should have at least one of those vaccinations, and after 65 they have one of those. This is old, recently updated. I apologize, but it's basically gonna be one shot after 65. Which of the following should be given patients with hypoglycemia with severe symptoms? Yeah, it just goes faster. You don't have to worry about You don't have to like worry about getting swapped to gut first and then having works. The IM glucagon is going to be the fastest in those options. GNC8, which of the following? So I'm going to switch gears a little bit to hypertension. So which of the following patients need treatment for hypertension?
I'm gonna say a medium for sure, but I can't remember what the specifics are for acute diabetes. To that age.
Okay. Yep. What's nice is that you don't treat diabetics or CKDs any different anymore based on JCA. The main thing you care about is going to be age. So the answer for this one is going to be D, 35-year-old blood pressure 145 over 85. So now the cutoff. So now the most important thing for you to think about for just whether they're at goal or not is, are they 60 or older or less than 60? If they're less than 60, it's traditional, what you have known throughout medical school of 140 over 90 hypertension treated. But with older patient groups, you start worrying a lot more about hypotension and falls. Literally, the most important thing we care about older people is for falling, okay? Because after a certain age, I think around 75, if they fall and break their hip, they have a 50% chance of dying that year, okay? With numbers that kind of intense, we worry a lot about falling. So that's why we, as opposed to like how much risk of complications they have having their blood pressure at 150 versus being at 140 is pretty minimal. And plus, like in general, like arteries just stiffen as you get older as well, so you tend to have a little bit higher blood pressure on baseline. So in general, we allow for people over 60 to have slightly higher systolic blood pressure. 90 is going to be the same across the board. Okay, so no matter what, are they 60 or higher, and then from there change your blood pressure goal. So looking back at that, D was the only one that qualifies based on the JNC guidelines. I want to say one of the cardiology associations recommend some, like, have a lot more stricter guidelines, but I believe you're only going to be tested on this. And more practically, this is an easier one to follow because I think it's literally keeping it at like 120 over 70 for some of those recommendations, which is like kind of a little too intense for in my book in terms of like in terms of like complications. They don't really start current until you hit like 140 or higher, and it kind of goes exponential based on how high it gets. So there's not, with that not really being a huge amount of like, risk being in like the 130s. I'm not sure if there's really that much it's worth it to treat that aggressively. So yeah, so technically you're at high blood pressure at 130 over 130, 139 or 80 over 90. Okay, technically, but we don't typically try to treat it until it gets to that stage 2 of 140 over 90. Okay, and then a hypertensive crisis is going to be 180 over 120 and or over 120. They can have a hypertensive urgency, kind of maybe starting like 160. Some people, they have like 160 over like 110, but they're like reporting like lightheadedness, some vision changes, like a headache. That's different. That's a possible sign of end organ damage, and so that counts as an urgency. Or no, actually automatically, if they have those symptoms, it counts as an emergency to have any sort of end organ sinus dysfunction. If it's just like it's urgency, meaning like they should be brought down, but they can actually be done that outpatient. But if they have any sort of end organ damage, they should be going to the emergency department and be admitted to have their blood pressure slowly lowered. This kind of follows what we're talking about. This is just that last slide in word form. Treatment of hypertension. So it basically decreases the risk of strokes, heart attack, heart failure. Basically, if BP is still above goal, you can talk about starting a second medication. So it's not totally abnormal for people to be on more than one blood pressure medications. Which of the following agents is first line for most patients presenting with hypertension and no comorbidities? Yep, D. Basically, if they had like ACE, ACE and ARB there, that would have been the correct answer as well. In most cases, it's sort of like it's kind of weird when it comes to African Americans with ACEs and ARBs. Just in general, like lisinopril, you have a risk of angioedema. Lisinopril only essentially has a risk of angioedema, just because of kind of this bradykinin release. So they might have like swollen lips and mouths and stuff like that. And at that point, that should stop it. What's funny is that it can happen at any time. Like a person could be on lisinopril for like years and years, and all of a sudden they can start having that at any point. So, does it stop me from putting having like keep African Americans on lisinopril? Not really. The prevalence limit on the angioedema is actually pretty low, but if it does happen, they tend to be African American. So it shouldn't fully preclude using like an ACE and like an ACE or like a lisinopril for a specific lisinopril for an African American, but something just to kind of like, I mean, something that's keeping in the back of your mind, or you start on like an ARB, like a losartan or something like that, and just as much benefits it has with that. But in general, apparently, so that as a class, ACEs and ARBs, they shouldn't be not quite as effective in African Americans, but like it's only marginally so. So that's why in general, like ACTC has been recommended in this situation. Oh, so I can't give the answer to the next question already. Like, so they shouldn't be. So ACEs are so in this part, amlodipine. Also, amlodipine is also a really valid. Amlodipine / calcium channel blockers are also great first line drugs for most people. Main thing is for people who have heart failure, maybe not so much, just because it can increase edema. Okay, which medication classes first? Which medication is recommended first line for hypertension diabetic patients? We talked about a lot about this already. C, yeah. Again, I told you about like the, oh no, small dose that some people get put on just to be on the safe side. Can be used for arrhythmias. This is a trick question because the ones that we use for arrhythmias are not the same ones that we use for blood pressure. Oh, there's a couple of these. There's a couple of these. Yeah, there's two answers to this question. Yeah. Yeah, you're right. So most of the time for a lot of arrhythmias, if they don't need to be urgently intervened, you just do rate control, all right, and not rhythm control. And so you oftentimes will just use a beta blocker to decrease that. So for example, someone has AFib, there's not real good treatment for AFib, unless it's like really bad. Then they might get like a pacemaker, but for the most part, what we do is to prevent from getting what's premature ventricular contractions, or PVCs, or rapid or with or kind of more like a rapid pulse, is basically making sure their heart rate never gets that high. So use beta blockers for that. Calcium channel blockers is also really good. That like the diltiazem, verapamil. So here's our kind of indications, contraindications. Basically, everyone with CHF should be on an ACE and ARB, a beta blocker, a diuretic, plus or minus an aldosterone antagonist. Okay. Yeah. So like really, like if you see a heart failure patient, they, like in general, like the ACE and ARBs are important. Kind of on the kidney end, but you want to be on a beta blocker because cardioselective beta blockers help your heart function. So people with CHF tend to do better with a beta blocker on top of it. So you see people that be put on all like 3 different types of medications for CHF, even if they don't exactly in their blood pressure, it's good. The aldosterone antagonist is like kind of a plus or minus. It's not exactly on for everyone, but just about all those other medications, basically all CHF patients should be with reduced ejection fraction should be on it. Preserved ejection fraction is a little bit trickier. Oftentimes you just kind of treat symptomatically and treat with their just regular blood pressure medications. MIs, same thing. ACE and ARB, beta blocker, plus or minus aldosterone antagonist. Um, uh, Proteinuric CKD, ACE and ARBs because it's renoprotective. Angina, beta blockers are very good for angina. Also, calcium channel blockers, you can do that as well. Yeah, they also don't. It's not put on here, but technically you can use alpha blockers for angina. Like so, for example, it's like nitroglycerin is an alpha blocker. AFib rate control. So we talk about rate control. Beta blockers, non-dihydropyridine calcium channel blockers. And then aflutter, you basically treat the exact same as AFib for the most part. On top of AFib, everyone should be on anticoagulation for AFib. It's not part of our discussion today, but it's good to just kind of give for repetition. Everyone with AFib should be on anticoagulation, unless they have a high rate of serious bleeds. So things to kind of consider for people with certain conditions. You can also use an alpha blocker for BPH. For example, the main one you use for that one is tamsulosin. And so the thing is, it has some blood pressure effects. It can be more pronounced in some of the elderly people, but most of the time people can tolerate pretty well. It's not going to drop your blood pressure too much. Central tremor beta blockers are good for tremors, like propranolol is a non-selective beta blocker that I've used sometimes for tremors. Hypothyroidism, beta blockers. I forgot. I think it works. I think the way it works, it helps with like the peripheral conversion of T4 to T3, and T3 is the more active form of the of thyroid. Migraines, you can use beta blockers, calcium channel blockers. You can actually use an ARB. I think Gordon likes to use a candesartan. So that's also an option for migraine. Osteoporosis, diazide diuretics, and then Raynaud's, you can use a dihydropyridine, like verapamil. So contraindications, we talked about angioedema, don't use any ACE inhibitors if they have it. Bronchospastic disease, don't use a beta blocker. If you think about what albuterol is, if you think about what albuterol is, it's a alpha blocker, right? So you don't it kind of will worsen disease as a result. Well, no, it's not even on beta blocker. It's a yeah, sorry, beta agonist. I'm sorry. Yeah, you're right. Beta agonist. I don't know why. Sorry, beta agonist. So if you're using a beta blocker, you're kind of contrary, you're kind of doing the exact opposite of what you're trying to do for that. Methyl dopa, I never use it. The only time I've ever really seen it used is on pregnant people because it's one of the few ones that are safe for pregnancy. Oh, like we talked about with those. Like, so don't use ACE, right? And second or third degree heart block, don't use beta blockers, not 100 beta blockers, not 100 pyridines, blockers unless there's a functioning pacemaker. Depression, Jerry recommends A2 agonists like clonidine, also beta blockers as well. Just because beta blockers can cause you to feel kind of lethargic, and that can worsen depression. Gout, avoid loop or diazide diuretics. Diazides decreases your excretion of uric acid specifically, and so you accumulate more uric acid in serum, and that can form together to form crystals into your joints. Hyperkalemia, avoid aldosterone antagonists, ACE, ARB, REN inhibitors, hyponatremia, avoid thiazide diuretics, renal vascular disease. Oh, it's weird. Like so renal vascular disease, because you see ACE and ARBs are renal protective, but then again it says avoid. It's a lot of that, from what I understand, is based off of their GFR. So if they have like a GFR above 30, there's a chance that they can benefit from an ACE and ARB. If it's lower than that, then it's not really it's not particularly beneficial from my understanding. Some to that degree. I think a lot of it seems to be based off of GFR. You have different data based on how good the current kidney function is. Which medication causes patients to feel tired? Yep, good, great anxiolytic for people for like performance anxiety, for people who need to give speeches. If you don't want to give them Xanax, which you probably shouldn't, you can give them a beta blocker and see how they do. Which causes cough and angioedema. Talked about this already. ACE inhibitors. I think we are really throwing this into I think we're really just kind of hammering these issues. Answer for this one. It's a little trickier because I don't really see that nearly as much as for that one.
It loops
Yeah.
that messes with the calcium and the potassium, and the calcium can cause blood clots.
I want to say this one was not. I think I remember this one possibly having two answers. I believe. I think for definitely loops, we worry about hypokalemia. But I think the correct answer for this one was like thiazide diuretics. Okay. Which of the following can cause these for arrhythmias? We talked about it. This one actually again has two answers, but beta blockers and calcium channel blockers, but specific calcium channel blockers. So those are so we kind of talked a lot about those different things. We're gonna kind of go through them again whenever we go through some of these questions. Yeah, we'll just kind of go through them. All right, so beta blockers, bronchospasms, bradycardia, may worsen insulin sensitivity, can cause coldness extremity, mass symptoms of hypoglycemia, can cause impotence. Thiazides can cause hypokalemia, hypomagnesemia, impaired glucose tolerance, hypercalcemia, impotence up to 20% of patients. Interesting. Well, let's talk quickly about thiazides and get on a small soapbox for that. So the most common one you're going to prescribe is that you can see around is HCTZ. And it's actually not that great of a thiazide, to be honest. The half-life of that is probably roughly around like 12 hours. It does so like most of the time people they'll use it, they'll check it during daytime, it'll look pretty good, but when you check blood pressure and come into nighttime, it's not going to be as controlled as some of the other ones. So the one that actually has mortality benefit amongst the thiazides is going to be chlorthalidone. So you're not going to see that nearly as much, but something that we should basically do a lot more because it has this better data around. We just kind of go to HCTZ because it's the most like widely available and this is the most common one that we see. But in general, like chlorthalidone that one actually truly lasts 24 hours, and it actually is the only one in that class that's shown to actually increase like decrease mortality rates on patients. Calcium channel blockers, risk of pill edema, constipation, bradycardia may worsen CHF. So when you think about calcium channel blockers, think about swelling. High doses of amlodipine can have kind of swelling all over, and that can worsen your CHF. We talk about ACEs and ARBs to death. Dry cough, angioedema, postural hypotension, is salt depleted, renal failure rare, high risk of bilateral renal artery stenosis, hypokalemia, teratogenicity. Thiazides, chlorthalidone preferred in basis of prolonged half-life. Oh yeah, talk about this. Monitor for hyponatremia, hypokalemia, monitor uric acid and uric calcium levels. That's why thiazides are good for osteoporotics because they maintain higher calcium levels, but not good for gout people, for gout patients. What we talked about earlier, ACE increases hyperkalemia, supplements potassium sparing drugs. There's a risk of acute renal failure with severe bilateral renal artery stenosis, which you're really going to come across, especially bilaterally. You're not going to come across that often. Patients with angioedema, talked about that. Avoiding pregnant women. ARBs, I feel like we're kind of repeating a lot of things, so I'm kind of going a little faster for all. ARBs, basically a lot of the same type things as ACEs, doesn't have the risk of angioedema. but otherwise exactly the same. Castor blockers, just related, dose dependent pedal edema, common females and males. So you have someone that already complain about swelling, you should be really putting them on amlodipine. Initial orders for hypertension, I'll have to get I don't typically get EKG to be honest, unless it's like, I don't know, really high or something. I rarely get EKG in hypertensive patients, but I do get BNP, lipid profile. I also check their CBC sometimes. So we'll talk about the side effects of the oral hypoglycemics. Sulfonylureas like lipozytes, hypoglycemia is the main one. Sensitive to light, GI upset, weight gain. By Meglitinides, hyperglycemia, weight gain. Biglycinides, lactic acidosis is the main thing. Diarrhea is not exactly accurate. I mean, it can cause diarrhea, but the main thing that people complain about with metformin is GI upset. But you can actually improve that by switching to an extended release form. That actually helps it over a chunk of time. So you see people on just regular metformin, you might have some issues. You switch them to like the extended release, they actually will generally complain about less GI upset. So TZDs, risk of CHF, mostly because you have an increased risk of swelling, hepatic dysfunction, weight gain, increased risk of fractures. We just don't use those anymore. Alpha glucosidase inhibitors as acarbose, GI problems. DDP4 can cause some allergic reactions, sore throat, headache, joint pains, pancreatitis. Ooh, what should you not combine? What should you not take if you're already on a DPP4? It's not on this list, but it's probably on the next slide. GLP-1s, yeah, exactly. Yeah, it works on the same pathway. So your chances of having these side effects increase a lot if you put on GLP-1. So that's something to be aware of. Those are only two that really, of the diabetic medications really interact with each other. So side effects of insulin, hypoglycemia, allergic reactions, basically at the site of injection, lipoatrophy, lipohypertrophy, insulin edema, and weight gain. All right, so let's go to the group quiz. We'll spend about like 15 minutes on it, and then we can go through the questions, okay? Feel free to take a quick break too if you need to. Yeah. I'll be right back.
Week one last week.
We have to turn this in.
It's a little confusing that they word it like view, but there's nothing actually.
I'm not even taking anything.
Oh,
Can I just look over your shoulder? Yeah.
I did this, I think I accidentally opened this last week. So I was looking for other stuff. Just gonna open the answer sheet.
can work together as a group on this. It's not really a test or anything. It's just so y'all can go through these questions, and some of it can be similar to what we already talked about. Does anyone want more time? Just go for it. Okay, sounds good. I guess we've been like 10 minutes, but I think if you're all ready, we'll just go ahead and go through it because all of this is kind of a regurgitation of some of the stuff that we already talked about. So, so number one, 41-year-old African American male was diagnosed with type 2 diabetes, elevated blood pressure, still elevated. What's your best choice for antihypertensive treatment? This patient. Sorry. Yeah, ideally you want to be on an ACE. Yeah, or technically should be an ARBS as African American,
I
but
think it says Hispanic on ours.
oh, really interesting. They must change it then. Shoot, maybe that's why because I always comment that it's incorrect that they finally change it. Okay, they're not some updated question, so hopefully it's the same. All right, next one. Most likely reason for failure to control blood pressure. Yeah. 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 So be like, oh, I just forgot to take it, or or yeah, often that's just like, oh, I forgot to take it, and oftentimes you recommend like, oh no, like putting your pills by your toothbrush, so you like, because you brush your teeth every day, at least you can see that you have pills that you can take and stuff like that. Those are kind of some things that can start to help compliance, or using like a pill box with like the days of the week, so that way they see if they still have pills that day, they'll know to take it. There are different ways you can help with compliance. All right, number 3, newly diagnosed 46-year-old male with hypertension, persistent asthma. Basically, hypertensive asthma. What should you avoid? Yep, we're talking about. Yeah, beta blockers will work great with beta agonists. Number 4, 70-year-old Native American female, here for routine care, has AFib and anticoagulation therapy, which will help control her heart rate. Of the ones available. Yeah, that's the only one of the non-dihydropyridines. The other ones, the amlodipine and the nifedipine, those are the dihydropyridines. They work by being vasodilators. But the non-DHP ones, the hydropyridine ones, they're going to be the ones that are better for kind of slowing down kind of AV nodal conductivity. And so that's how it would help with arrhythmias. But they're not great vasodilators, so you wouldn't really be put someone on. You shouldn't really could go on antidepressant for blood pressure specifically, because it's not good at that. All right, 5. History of migraines, high blood pressure. What should you put her on? Yeah, the answer in this particular situation is B. 6, 65-year-old African male with type 2 diabetes, congestive heart failure. It's on metformin. Which of the following would be least appropriate? So which of the following causes, let's say, edema? Yeah, say the pioglitazone is the one notorious for causing edema. 7. Adult patient with type 2 diabetes, hypertension, taking metformin, glyburide, pioglitazone, lisinopril, hydrochlorothiazide. Recently lost some weight, but now it's having hypoglycemia during the day. So which of these causes hypoglycemia that we talked about?
C.
Yeah. Yep. All right. 8. New patient yours recently diagnosed with diabetes and hypertension. Weight today is 220. Height 5'3". BP is 162 over 100. Random blood glucose is 240. Which will prevent the most complications of diabetes and hypertension for Christina? Yeah, for sure. Those will help both diabetes and high blood pressure. Okay. All right. 56-year-old male, Native American male, new diagnosis type 2 diabetes, A1C of 9.6, creatinine of 2.5. Which of following therapies is contraindicated in Nicholas at this time? Yeah, metformin, like the risk of lactic acidosis goes up when the GFR is really low, which is what a creatinine 2.4 will probably be equal to, like maybe like a 10 or something like that, or 12. It's pretty high. Let's see. Last one. Allison's a 34-year-old patient of yours who's taken care of since she was an infant. Healthy, tries to eat right. Comes to you concerned about a wound on her left leg. It took about a month to heal. Only past model history of spontaneous vaginal delivery. So it's an atrophic, hypopigmented, one centimeter skin, shiny area of hypopigmented skin on diameter in the left outer calf, no erythema, no tenderness at the time. What do you think it is? Yeah, you're like, oh, the thing that we're studying today. Yeah, I forgot what the specific term for this one is. It's like a diabetic. Diabetic. I forgot what it was called. It's kind of like name for it. Diabetic rash. There's a couple of them, but let me see. The one they're talking about is a really specific name. So it's like it's diabetic dermopathy. It's a general term, but I feel like there's like a more specific term for it somewhere. But yeah, this is diabetic dermopathy, and I think I think it's a result of the same things we talked about with microvascular issues, poor circulation in that area, leading to atrophic skin, essentially. So yeah, good. Even though if I saw that, I'm not sure if I would have went to that immediately. To be honest, like, it's not. I don't think it's not particularly common. All right, last couple things, and then start again. I can also get you out with enjoyment. All right, let's talk about the group case discussion real fast. All right, so this is a 54-year-old male. I wonder, this is Bob. It might be Bob, who has high blood pressure for over a year. Now only has a random glucose reading 300 on office visit. Will admit that he has diabetes. Previous heart attack, taking several medications. He admits to feeling a little tired recently, has been getting up at night to at least 2 or 3 times per week. He sees your preceptor for care and expects top-notch care. Those are the medications that he is on. Let me see. A1C is still pretty high. A1C is still pretty high at 10.2. Creatinine is 0.8. Microalbuminuria is negative, meaning he doesn't have at least signs of chronic kidney disease at this moment. What is your recommendation at this time? Not quite, but it's part of what he needs. I think at the very least that's what he should be on. But he probably needs something more than that. Yeah, there's a couple of things. Yeah, for sure. So he's already on metoprolol, ACTZ. He should probably be on. Let's talk about one by one. I think the easy one to answer right now is going to be the blood pressure one. What should be added for blood pressure? Yeah. Thanks. All right, so good. So that should be able to help him bring his blood pressure down. But now we need to talk about his A1C. So we talked about metformin. So he definitely should be at least on metformin. But what else should he be on? I'm trying to look at the specific guidelines, but I'm pretty sure that if it's above 9, it's an indication to start insulin immediately. It's either 9 or 8. It might be one of these other ones. Give me a second. What guidelines used to look? I feel like I looked at it the other day and it was saying 9, and it's also different now as well. Because let me see, there's this one here that talks about it. But anyways, I think it's actually 9. I want to say that the one I looked at was saying, like, I literally saw this like a month ago. So I think it's about 9 or above. You want to, it's just because the medication you're putting on is probably not good enough. He probably has pretty decreased pancreatic function at this point if it got that high. So you should so the guideline for this part is going to be either metformin and insulin. And the new changes to that guideline was you can also, an option is to also do metformin and a GLP-1. So in the situation, it'll be so you can use either. I would probably lean towards the GLP-1, especially if they go from someone who has not been giving himself insulin ever to having to do that, 4 times a day, possibly up to 4 times a day. That can be that's a hard pill to swallow for a lot of people. And so versus you get them on like an inject, like a once a week injection, they'll be like, oh, I take that every day, any day of the week, basically. It's just like any like just because it's just so much easier, and you can actually titrate up quite a bit. But people like this, they're insulin naive. They're only you would probably not even need to be on a whole lot of insulin too. You probably would start pretty low. And generally, what you want to do is you calculate their kilograms, and I believe you start around about zero point 0.2 to zero point 0.3 um, units per kg. So you calculate their weight, and that's how much you can expect their insulin requirement to be. Ideally, what you want to do is put them on a basal bolus regimen for insulin. So you ideally you want to do 50% of insulin through basal and 50% through short-acting insulin. Um, there's a risk of something called over basalization. So the easy part is to give basal. Maybe for some people you just do basal and they're able to kind of stay within good range most of the time. They don't need a whole lot of short acting insulin, and that's okay to a certain degree. But once it gets to the higher dose, your risk is something called over basalization, and that which like no matter what you increase, if you start to increase your basal dosage, you'll have like much more limited return or effect based on how much for each additional unit. I think after about like um 0.4 mgs per kg or something like that, something to that effect. And so you're just kind of wasting insulin at that point. So you have people that are on like 100 units of Lantus, and that is like absurd. It's like it probably wasn't doing anything beyond maybe 60 units of Lantus. Okay, time they're just gonna get themselves in trouble, and just like so they should be put, and then people will be like, why is this person's like A1C not under control? Well, it's because you need to do some short acting ones, because your basal is not effective at that higher dosage now. It's newer. I'm not sure if they taught you about that in medical school, but it's starting to become like a big thing that we start care about is over basalization, because it's just too easy. It's like you can give yourself one injection a day, or you can give yourself 4 injections a day. And people just want to do one injection a day if they can go with the basal. And you can with with just like the really, like for people who are insulin naive and not requiring a whole lot. But once you get over a certain amount, it's just you're not going to have limited returns, because you'll be like, this person's on 120 units of glargine a day now. What's happening? Why can't it be under control? And it's because it's not effective. Your body just doesn't respond that way. It needs short acting in order to make up that difference. So sometimes with a certain amount, you should be kind of maybe going towards like a 50-50 of like your short acting and long acting. This is more advanced. This is definitely more resident level stuff, because you're not gonna have to start anyone on insulin kind of where you're at, or just to kind of let you know how tricky it is for insulin management. That's kind of like some of the things we think about. Okay, let's talk about the article fast, and we'll be done. Did you all get a chance to read the article beforehand? It's okay if you have to be honest. Y'all are busy enough. And this is supposed to be your more easygoing rotation, so I understand. Um, um, except for whenever you had to study for the shelf on this. Before we used to have when I had this clerkship, they have proprietary test that was pretty fair and mostly focused on preventative guidelines on top of like kind of basic medical stuff. But now it seems like the shelf is like basically your IM shelf, but only having a month to study for. So I understand why they could be more stressful. So I'm not gonna hound on you reading this random article. um, so this one, the basic idea is like how it talks about how with the internet and people having more access to information, but about how would you react to a patient who brought their own research for you. Okay. Yeah, just to think about how would you personally react if a person, let's say a person, they say like, hell, I've read about this thing, could we try this medication out, and they give you like a little print off. How would you feel about that?
I would ask them what their understanding of that medication is and what's their expectations.
Okay, cool. Anyone else?
I would check first to see like what they
What?
actually know and compare it against the line.
Yeah,
And then I would be pretty happy.
Yeah.
They did a lot of work.
yeah, for sure. No, that's definitely been a case for me a couple times in the past.
Yeah, the validity of the source I would measure. If they gave me a printout of up to date, I'd be like, yeah, exactly.
Oh yeah, that's good. Like yeah, all right. Yeah, I think it's kind of that's that's kind of what I kind of based on like what I would do. Some people can get a little bit offended by it, because you're kind of like the expert. You don't want to spend all the time in medical school to learn all this. You learn like cocktail theories and all that stuff and pharmacology. If this person here, did a Google search and did some of that. So some people, so it's easy to kind of feel a little defensive about that sometimes too. The problem, like, and so part of modern medicine nowadays is that we're going beyond kind of more of a kind of a patriarchal, like, do this, you're being naughty, do this, like, listen to me, I'm the authority kind of situation, to more of a kind of a collaborative kind of model of medicine. What they found is that basically for the most part, like, if you like the patient has to agree with you, for them to do anything for the most part, right? They have to agree with you. And if you just say like, no, just do this, and just kind of dismiss them, they might just kind of not do things on the spot. Okay, you'll see that. It'll be like, no, I that's not good. Like, we're not gonna do that. We're just gonna do this. And at that point, they're not gonna feel listened to. They're gonna feel like you don't really know them as a person. They're gonna feel disconnected from you as like their provider and stuff. So it's important to take into account what they're saying. It's like we were saying, just maybe check their sources and be like, I think this person's blog. I don't know if this is a good source of information. Like, I mean, let me show you what I see, and you can bring up to date or whatnot, a specific thing. So this is done by Mayo. This is a study done by them. This is a study done by multiple medical colleges, and you can kind of educate them on that end as well. I definitely have occasions where it was been extremely frustrating. I mean, like, this literally happened last week. I was on the OB inpatient service. We take care of OB and newborn patients, and we had a baby that had a subgaleal hematoma. And if you know how rare that is, it's pretty significant. Most of the time, people have capit or um, capit or a cephalohematoma, which is way more common, but 7 out of 100,000 of those cases are going to be subgaleal hematomas. So we caught this, and the dangerous part of subgaleal hematomas is that it fills in a space that's between your skin and your dura that has a lot of room for blood flow, and so the baby can so babies, and it doesn't have usually as much of a pronounced like bump. It's mostly like more wider distributed, so it's kind of insidious in that, like, if you don't have a high suspicion for it, you're not going to catch it, because it's just like, it'll be like, wait a minute, the baby's head looked bigger to me. I basically the resident that caught it did an amazing job. He was like, hey, I think the baby's head looks bigger and it feels weird. It feels like a little like mushier than what I saw yesterday. I'm like, that's a good point. Let's go check it out. And then we ordered ultrasound afterwards. It confirmed a subgaleal hematoma. The problem with this specific situation is that this family refused everything. They refused a hepatitis B, erythromycin eye drops we give for all babies, and they, more importantly, they refuse vitamin K. All right, and so the purpose of vitamin K shots for newborns is that they don't produce their own clotting factors very much at that age, mostly because like the liver's not working 100%. They're not getting a lot of dietary vitamin K either, so their circulating amounts of that is really low. The only way to really, like, there's no other way, like, there's no method more effective than doing an IM vitamin K shot, because it goes into circulation quicker. They're able to perform that, to create clotting factors a lot faster. They compare it to oral vitamin K, and it's not even close, and the family was like, I don't want it. It's like, your baby is bleeding into his head right now, like, I think it's a good idea for the patient for the baby to be on it. I mean, it can risk of like bleeding out, it can be risk of dying. They're like, no, I don't want to do it. I was like, I know, it's like, for the most part, we want every baby to get it. I'm okay with some people refusing it some of the time, as long as we're careful and make sure the baby don't bump their head into things and accidentally bleed into their brain. But in this case, this baby is bleeding. This baby has known bleeding into a place that tends to keep on going. I think we should get this. And like, no, I did my research. I don't want to do it. Like, And so it's just like, and so the best thing you can, so at this point, it's all about like autonomy and like who gets to decide on what. Um, and so I even asked her, it's like, okay, so like, what are your reservations against that? I'm worried about I'm worried about the side effects. Like, okay, like what side effects? I don't know, but I read some stuff. Like, okay, like, where do you, where'd you get this information from? Oh, like I talked to my sister and I saw a few websites. I was like, okay, like what websites are you looking into? Like, and then she's like, I can't, I don't know. And then she's like, and so I just don't want it. And so at this point, I'm just like ready to call DHS on this family, you know. But fortunately, this baby's bleed, like this baby's like hemoglobin remains stable, so it looks like it's not bleeding. So it's not to the point where we have to give it to this baby. But at the same time, it's like I'm saying, like there's no chance, like there's no guarantee that it's not going to come back. You know, there's no guarantee that it's stopped for good. There's also no guarantee that the baby hit his head at any point, you know, just by playing around. That might not bleed into his head and die, you know. And this does happen with people who refuse vitamin K, you know. So like, given all this, like, do you think any of the side effects you're worried about is worse than what I'm talking to you about right now? It's like, no, but I don't want to get it. And then at that point, the husband got real defensive and got in my face like, we don't want to get it, you know. It's like, and I just took in the face like I'm just saying that right now we're just on the cusp of giving it to the baby, even if we want it or not. That's where we are right now. And then and then basically it was not bad. It was, I could have kept my cool a little bit better at that point, but at this I was just so frustrated because there was not great answers. Like, didn't have good evidence to back it up. They can't even give me the sources. And the best you can do is just keep watching. And so we made sure the baby had a close follow up. They've been followed up in a clinic, and we've been measuring the baby's head like every week just to make sure it's not growing, because it's kind of like it get the blood accumulates like outside of the skull, so you can actually see a noticeable change in like the head circumference with it. And so, but the baby's doing okay, as they're doing good, no issues. But I'm just like so worried. And at that point, it's like, I don't know. At what point do we need to get like DHS involved with this case? Because like, but at the same time, it's like, I don't know. It's kind of within their right as parents to refuse, but it's a tricky situation when it comes to children. I think before 18, if it's life saving, you have. I think you're legally obligated to do something despite their religion, despite any sort of like personal beliefs. Like I think Jehovah's. Like I think if you get tested on like step, you have like a Jehovah's Witness that was in a car accident, like it has a car accident with like a 12-year-old. I think the answer was to still give a blood transfusion, because that at that point that child did not have the autonomy to make that choice that's relating to her life, you know. And so you're kind of obligated to take care of them. And that's kind of where I feel like we were heading towards for this baby. It was real bad. And I mean I was really frustrated. I definitely was like, you know, it's like, hey, what do you like, you know, like what are your concerns about it? Like, let me tell you about my concerns. And I definitely used the soft touch at first, but then I had to go for scary. And then that didn't work. And then I just had to be like, this is the matter of fact the situation is. This baby has a 7 out of 100,000 type of brain bleed. It's really rare, but really severe. Oftentimes, these babies need to go to ICU. Oftentimes, they need a blood transfusion. You know, and they can die from this. You know, it's not uncommon for them to die from this. And I think right now the baby needs this. Like if this was my child, I'll give it 100%. Everyone in this room got a vitamin K shot, including me, all the residents, all the nurses. We are doing fine. We have no problems with it. Never been. This is a vitamin that's naturally in foods. It's not a chemical. I believe this is. I strongly and no, until like I can't strongly recommend this enough. But like, no. Like, and at that point, it's just like, okay, I just need to step out of this room, or else I want to like yell and scream at these people. Um, but that's gonna be how you can get sometimes too, and that's kind of the new age that we live in, especially when you say with COVID and everything. It's just like people are just so hesitant to like they're so like this critical of their doctors because just all the misinformation that's out there, and the people are just kind of spinning like the doctors are like trying to kill them for some reason, you know, as if like we have some sort of something to gain from like, I don't know, hurting people, you know. And so sometimes it's for that in those cases you just have to if you have the emotional capacity for it at the moment. I understand if things get really busy, you might have like clinic, you just might be really tired, you're running on like 4 hours of sleep. You might just not have that fight in you, then that's fine. Just document that you talked about it, and then just go on. It's like this. I can't tell you enough. This is what I recommend. This is what I would do for my family. And they're like, no, at that point, you just move on for a lot of things. But if you have the fight in you, it's worth it to spend the time with them and kind of discuss, kind of get down to like what their beliefs are, and like beliefs around this specific thing, and see if you can kind of like address in each of their points, and you'll be surprised how more people you can sway through that. Okay, especially you can show that you're knowledgeable, that you know what you're doing, that you're not just trying to hurt them for some reason, like for example, like COVID vaccines, like, oh, I don't try experimental medication. It's like, well, at this point, probably close to 1 billion people have gotten it now. I think we can say that's pretty safe, And so be like, I didn't think about it like that, like literally like hundreds of millions of people have had this now, have gotten the vaccine now, and now had that didn't have any. Then the data shown it's not, there's some issues, but not as often as people will make it out to be. And you'd be surprised how some people can be swayed by that, but they're all kind of like emotional driven, and they're at a point where just like emotionally cut off and walled off, and they're like in like this, like, I don't know, defensive mode the whole time. You're not going to change your mind. You're just not. You're just going to be like, nope, I know, I see what it does. I'm not going to do it. But okay, it's much better. It's like I like, and there's a certain degree in which you can kind of gauge their ability to actually take the sample information. But there's some people they're just brick walls, and you just can get real depressed afterwards, and depressed and tired afterwards. So that's something that's to keep in mind when you're dealing with any sort of patients when they have like disagreeing thoughts based on their online research. And sometimes they have really good ones. I definitely had occasions in which patients like, hey, like I heard about this new medication. Do you think I can like it'll be a good medication for me? And then I'll be like, oh, I never heard about this like drug class at all. Let me read about it real quick. And I was like, read about it. It's like, oh, it's pretty safe. It doesn't have any contraindications. Let's go ahead and try it. And or be like, hey, I'm taking this vitamin. I heard it's gonna be good about good thing. Like I heard it could be helpful for that. And I'd be like, yeah, I heard that it could be helpful, but I don't see strong evidence for it. But at the very least, it doesn't look like it will interfere with anything, and it won't cause any harm. So it's worth to try it. At that point, they'll feel like they're listened to. It's not going to harm them. At the very worst, it does nothing. At the best, it improves. Why not do it? That kind of stuff. And so yeah, and sometimes patients will come in with your answers for you. Be like, hey, I think I have this. Can I get this? And you're like, oh yeah, that looks all right. And you just gotta verify the information a bit, and they're like, yeah, let's just do that. And then like that, then at that point they do your job for you to a certain degree as well. So it varies quite a bit. It can go anywhere from you wanting to strangle your patient to you feeling like they're like super knowledgeable, and that they make your life a lot easier by making the effort to do that kind of work. So that's kind of how my thoughts on this whole virtual mentor thing. It's definitely a double-edged sword for sure, and I definitely see more I don't know, criticism, or just kind of like more pessimism towards like doctors, at least, or at least like just like there's like they're just so much more defensive about things, and it's I feel like it's probably a little bit worse than it has been in the past, thanks to the availability of information. But sometimes these people just don't know. Like I literally tell people, like, for the COVID vaccine, it's like, this is an mRNA vaccine. So what and it's only for the outside of the vaccine. All the vaccines previously was basically we have parts of we have either viruses that we inactivate that doesn't cause illness, so your body recognizes. So we're just injecting inactive viruses into you, or broken up pieces of the virus. This one is only just the outside of the virus that we care about. So in terms of you having a negative reaction to that, it's a lot lower. This is the thousands of proteins a virus might have, that you can somehow maybe develop an autoimmune reaction to. I think this type of vaccine is going to be the type of vaccines we're going to get in the future, and to be helpful for decreasing the amount of side effects we have as a result of it. And so I have some people that really, like, no one has ever explained to me like that. That makes a lot of sense. and they'll agree to it. You know, at that point, I take a victory of like, yes. Even though it's like it's so like draining in the middle of like busy clinic, you have like patients waiting on you, but you're trying to convince them to do it. Especially they have like a lot of comorbidities like COPD and heart failure. COVID's gonna tear them up. COVID's gonna destroy them. And so you have to like and during those times you have to be like I can't recommend this strongly enough for you. And so like literally if you're my mom, my dad, like someone I care about you, but not as much as my mom and dad, I would do this. Like I would tell them to get this, and it's, they that's like kind of some terms of which they can kind of relate with. Okay. So this I spend most of the time talking about hypertension, diabetes, but a lot of it's like it's good to expose y'all to kind of like the art of medicine and taking care of people and and uh, and having to just deal with the interpersonal dynamics involved because it's way more complicated. You can be 100% right? You can be like, according to the guidelines, you should be on this, and you'd be 100% right. But if you can't convince a patient that it's right for them, they're not going to do it, and it'll be just the same thing as you doing it being absolutely wrong. It's going to be the same outcome. I think you still the problem is not going to be fixed. So a lot of it is having to work with your patients and being in a more collaborative environment that they like you and they'll listen to you and want to see you again, follow up and everything. And when you do that, you'll enjoy your job a lot more as well. Okay. All right. That's my soapbox for the day. Dang, went 3 minutes longer than I wanted, but hopefully that was helpful for you all. Yeah.
Been a good hang, folks.